To all our participants and viewers, whether it be morning, afternoon, or evening for you. I am Karen Timmons, CEO of the Global Healthcare Accreditation Program for Medical Travel Services. GHA, as we are commonly known, was formed in 2016 to share best practices and set the standards for care for those growing number of individuals from around the globe who travel for healthcare, driven by disparate motivations such as more affordable care, better and quicker access to care, higher quality of care, specialty, treatments and procedures not available in their home country, and sometimes for privacy. GHA standards developed by stakeholders, including providers, insurers, facilitators, and experts in medical travel, are recognized as international standards by the International Society for Quality and take a deep dive into the complex medical travel continuum, including issues related to pre-arrival and post-discharge, setting accountabilities, patient bill of rights, ethical practices, excellent patient experience, cultural competency, and language fluency, to name a few, including dietary needs, hospitality, providing the medical records to patients upon discharge to ensure their continuity of care, and sustainable business practices that impact medical travelers, to name just a few. Patients Beyond Borders estimated that approximately 21 to 26 million global patients would cross borders to receive care in 2020, with a market size approximating 74 to 92 billion US dollars. And then a global pandemic hit in early 2020, causing countries to close borders, airlines to stop flying, and issuing unprecedented orders for citizens to stay at home in an effort to mitigate this highly contagious and impactful virus. Today, we are very fortunate to be joined by leading hospitals and experts around the globe who have medical travel programs. Our objective is to learn together how countries and hospitals are managing through the COVID-19 challenge and how together we may develop a medical travel strategy for sustainability moving forward. Joining me today are Dr. Cho Jong-hook, Director of the International Healthcare Center at Seoul National University Bundaek Hospital, Dr. Haitham Hussain, Vice President and Medical Director International at Cedars-Sinai Medical Center in the US, and Dr. Korpong Mukhapan, Chief Executive Consultant, Head of the COVID-19 Command Center, Bumrungrad International Hospital in Thailand. All of these hospitals, I am proud to say, are GHA clients. Dr. John Lucas, CEO of City International Hospital in Ho Chi Minh, Vietnam, was unable to join us for this webinar and was pre-recorded. His segment will be integrated into this webinar following the taping today and will be available on our website for viewing. As we begin, I will ask each panelist to provide a general overview of the approach used in your country and organization to mitigate the risk of COVID-19 and manage the pandemic, including IC guidelines or protocols. Dr. Cho, we will begin with South Korea and your experience at Seoul National. South Korea has been recognized for its flattening of the curve, and we are eager to learn from you. Dr. Cho?
Thank you, Karen. To start with, I just briefly introduce our institution and what we have been employing since January this year to fight against this COVID-19 situations. Our campus is at the outskirts of Seoul. It's one of the major teaching hospitals of the university with a bed capacity about 1,400. And since January, the institution embarked on a few projects or the processes to mitigate the risk of the patient as well as medical personnel. And to start with January, we established the screening of all the people entering the hospital before they enter the hospital building. So there were 5 entrances in addition to the emergency room. There were we established the checkpoint by staff with the hospital employees that including nurses and non-medical personnel. So they check the temperature and questionnaire every personnel trying to enter the hospital, and they triage these people who wants to get into the hospital depending on the symptoms or purpose, and they give the entrance permit to the hospital campus. And at the same time, hospital established to sort of a container type of clinics outside the building to triage the patients with any respiratory symptoms or visitors with any respiratory symptoms, staffed with medical staffs of different specialties since January. And from there, the patients will be triaged to there's another a triage clinic adjacent to the emergency room for highly suspicious COVID-19 patients, where the triage again the patient into the admission to regular isolation ward versus negative pressure isolation versus high grade the intensive care unit for designed for COVID-19 patients, confirmed cases or highly suspicious cases. So there that's been going on since the middle of January this year. So from this screening process, patient go back home or admitted to the regular respiratory isolation ward or the negative pressure isolation ward or the intensive care type of COVID-19 floor. So that's been going on. That's a major things we embarked since January on this issues. So.
Okay, thank you very much. Dr. Hassan, would you like to share Cedars-Sinai's experience?
Well, certainly, thanks, Karen, and sort of good afternoon anyway from Los Angeles to everyone on who's watching live. And I think these are unprecedented times, and there's really no need to sort of restate that. So I think everything is in very dynamic in flux. We've been, I myself, I will give a brief snapshot, and I'm going to focus a little more on an international program. I'm a vascular surgeon and practicing one, dealing with, I'm not an infection disease specialist or infection control or epidemiology specialist. We have an amazing team at Cedars-Sinai and have been working collaboratively both locally, nationally, and internationally, as I just learned that Dr. Cho was on a call with our team recently. I think, the way it looks to us, our program is a major one, I would say, international patient services among the, major U.S. hospitals. We get somewhere around 2,500 patients or so a year. And now, but, for us, it's a little bit different because LA is really a global hub as a city. We get patients from over 100 countries. And although I think our major footprints are similar to other major U.S. academic medical centers, it's our neighboring countries, Mexico and Canada, rely on our services, and it's the Gulf countries, the GCC countries, Saudi, UAE, Kuwait, and Qatar primarily. And of course, we have a strong footprint in patients from China, many of whom don't necessarily travel immediately, but come to LA for family or business or other reasons. So, if you look at the trends for us, I think, believe it or not, up until early March, we actually had no decrease in the volume of patients coming here. And if I look at our timestamp of events, which our team is sort of monitoring, if you look at January, there's a decent amount of events that we were monitoring. Unfortunately, February was a little bit, not so many events, and then in March it's sort of exploded. So the reason I bring that up is if you just look at it from that way, I think we've been a little bit behind the curve to some of my panelists in the countries they're in, and not necessarily appreciating the risk. We appreciate that early on. But activating and moving and doing things.
Mm-hmm.
I think today, Cedars-Sinai, similar to what Dr. Cho was mentioning, has done, I think it was about, well, actually, it was exactly a week ago that we stopped elective surgical cases. And I think that's an important timestamp, because that kind of, sort of indicates when the hospital has shifted formally its major operations from a essentially normal operating procedures into sort of this acute mode. And since then, it's been quite rapidly shutting down our clinics and our elective procedures, and shifting to reorganizing the hospital. And many of the things, as was mentioned earlier, changing the way you can enter the hospital, monitoring those who are coming in, eliminating visitors, et cetera, et cetera. We've recently actually gone into some, I would mention, sort of like virtual, we've actually set up a separate ICU, but we've also going into like virtual ICU consults. So even within the hospital, rather than having to protect our PPE and to protect our healthcare workers, there's a number of things that are happening. One that comes to mind that wasn't mentioned was trying to, even within the hospital construct, trying to eliminate movement between units, use of some of the equipment, utilize some of our technologies to communicate effectively, so that we can manage patients that are in the hospital. That doesn't even, I imagine you'll have more questions and comments about other things like telemedicine, and we can dive into that later. I think, certainly right now today, as I mentioned, well, I actually didn't really mention, but sort of, I would say the tipping point was around a little less than 2 weeks ago when we started seeing, and it was almost incredibly concomitantly or amazingly that patients started calling and are concerned and canceling their appointments. And at the same time, as we were mobilizing and some of the, as a country, where some of the flights and visas and what have you were becoming restricted to some major areas around the world to us. So we didn't really see a trend before almost the regulatory events caught up with us at the same time. So I think today we're just reshifting our energy towards attacking this pandemic. We are fully, we've moved to working from home unless you have to be taking care of a patient. And I think it's going well. I think our business is continuing. If you think about our global collaborations, global services, some of the content is shifting, of course. And lastly, I would just say that because we have such strong ties and relationships in China, I think we've been, the international program has had our eye on this since the beginning, and we're not so much broadsided by this, quite frankly, and have been thinking about it. But no doubt the country, our state, our hospital has, really had to change our lives very quickly, like almost all of you. And it's a dynamic process.
Well, thank you very much, Dr. Hassan, for sharing your perspective on this. And now we'll turn to Dr. Korpong and your experience in Thailand, as well as Bumrungrad, which also is all of your hospitals are leading international medical travel destinations and centers. So Dr. Korpong?
Yes, it is 9 o'clock at night, but all the lights is open up. We have been working very hard for almost 3 months. I would say one, Thailand is preparing for this, especially Bumrungrad. We have a long-standing experience dealing with this kind of outbreak. If you would recall, in 2015, we could be able to identify the first MERS infection in Thailand, and we're treating it well. The patient has go back home alive, and from that particular lesson also raise up our concern regarding the risk assessment and all those emerging diseases. Sometime last year, we conduct an annual risk assessment, and we all know that the World Economic Forum identified as the emerging diseases is one of the global risks. And on top of our long-standing experience, we relook into our infectious control program once again, and we look at our resources and look through our facilities. I'm lucky enough to be in charge of the both of the outbreak, the MERS and this time again COVID-19. In January the 3rd, we activate what we call the virtual hospital incident command system. So what I would like to share is everyone in healthcare industry needs to be agile, needs to be flexible, adaptable to external environment changes. In January the 3rd, we activate the virtual HICS, and from that we relook again and be ready. I and my team start to do the ready check in every perspective, from the front door to the back end. So from that, we plan carefully to be one step ahead of the game. We are predicting during the Chinese New Year, sometime in mid of February, to be the time that a lot of Thai people traveling to China, coming back to Thailand, or the Chinese people coming to Thailand to celebrate the Chinese New Year. And again, next month, we have the traditional Thai New Year event. We are lucky that the government announced that we will not celebrate Thailand New Year event we call Songkran. So those are another factors, not only the organization itself to be ready, but we need to assess the external factors, especially in Thailand experience, the Chinese New Year, the Thailand New Year, etc. What I want to add on top is we have, even if we are private hospital, we have a very strong foundation on academic team. I and the top management appoint the scientific team to help us, because this COVID-19 is the novel infection. So we have less knowledge on this part. So that particular scientific team helps us a lot in terms of advice on the update study, publications, programs, medications, result of the outcomes and protocols. Those are the critical point that we on top into the HICS that we currently have. We pretty much focus on how possible that we could be able to detach everything from the main campus. Karen, my experience with our facilities, we have two big buildings. We have 21 floors as outpatients. We have 12 floors for inpatients, and we have another floors for the other services. So we carefully review what are the transportation and movement in the campus, and we try very much to detach the facilities, the service, workflow, and the people into that particular building. So that might be the quick brief for the round one from my side. Thank you.
Well, thank you very much, Dr. Korpong, and that is a very interesting perspective. Before we move on, do any of the panelists have any questions or comments that they would like to ask each other or add another perspective? We'll be moving on to another topic next. Just wanted to ask. Okay. All right. Our next question highlights disruptions experienced in medical travel volume due to COVID-19. We understand that disruptions have obviously occurred due to border closings and airline stoppages to curtail the spread of the virus. But as our panelists are facing different stages of the disease, of the progression of the virus, perhaps you can share some of the strategies you have deployed when first communicating with your patients or in screening of the medical travel patients. Were pre-screening criteria implemented or revised in any way, or special protocols adopted just for those medical travel patients that might be different from the patients from the community? And Dr. Hassan, I'd like to start with you at this point.
Thanks, Karen. So, I mean, I think yeah, absolutely similar to previous outbreaks, such as MERS and other ones, you know, it's very important to identify very early where the outbreaks are and where the so we begin to screen our patients coming from those countries. So it's similar in this case. Immediately, obviously, we began to screen, and it's usually a very short questionnaire, and you know, the types of questions that are required or suggested by the CDC. So we screened patients from China, and then that was the first, of course, and then expand to a few other countries. And then as time went on, rapidly increased into the European countries and others. You know, I think now, you know, as a corollary to that, I'd like to say that now, you know, the topic's very interesting because it's at the crux of, is healthcare local or global? And it's on the minds of all of us. I know certainly you and I think about this every day. And you know, right now, truly, it's a community event. So we're experiencing something that is starting as a global event, but at the same time, it's local to some countries, some communities. But today is truly a global event. There's not one person on this planet, essentially, or one hospital or one institution that's not affected by this and has to adopt, you know, sort of local measures based upon our own culture of delivering care. So, you know, I think, you know, we did start with screening. I think the other thing I would mention is it's very important to, from a medical travel perspective, is to have effective communications, and that means externally and internally. So we establish lines of communication with our patients, not just about, hey, screening, do you have fever, cough, shortness of breath if you're coming from certain countries, but also alerting patients traveling from other countries. Have they traveled to X, Y, and Z? Do they understand the impact of what's happening around the world and that sort of thing? And at the same time, we communicate internally and take the lead as our international program so that everyone we were a bit ahead of the rest of our institution, I would say, naturally, about alerting about the risks and the potential impact of this, not only on patients in our hospital, but our faculty, our physicians, our business people traveling overseas. And so we maintain that alert system for the organization. So I would say, on top of screening patients, I think the next thing is very important to consider is the communications and how you communicate. And so I'll leave it at there because I'm sure there's other points to make that other panelists might want to. Those are the first two things that come onto my mind when I think about our immediate response to potential medical travelers.
Okay. Well, thank you very much, Dr. Hassan. And Dr. Korpong, we'll go to you next, and if you could share Bumagrad's experience.
What I would like to add on top is that what we do screen at the moment is not only for COVID. This is very critical, important, because right now we just add, for instance, on January the 4th, we add Wuhan city into our screening protocol on top of the SARS, Ebola, and MERS screening. So in the system, in our hospital information system, we have that particular sheet for screening, and those still exist. Not only COVID, but MERS and SARS and other things. I think one thing is the good thing of digital technology at the moment. We are pretty much be updated by all channels. Once we got the WHO China informed the 44 cases of unknown pneumonia on January 3rd, Bumagad add Wuhan city to be one of the screening destination. And once we got the information that the China government closed down Wuhan city on January 22nd and closed down another 4 cities on January the 23rd, we add and adjust not only Wuhan at the moment, it is the whole China. Even the Chinese government announced only 4 cities to be closing down. We shall not compromise on those risks. The command center agreed to screen all the Chinese people from, to screen all people from China, the whole country, which is something that we are one step ahead of Thailand country as well. So I would like to add on the what exactly you screen in your screening protocol. And once you screen, it is not just the one layer of the screening point. In Bamrungrad, we have 5 layers. Every entrance of all buildings, we designate the foot traffic, the transportation, logistics into 5 point of entries. And that is the starting point. The clinic buildings, where we have around 3,000 people coming in every day, we have the second layer on top with the thermal scanner. We have the third layer at all registration counter, repeating and reassessing, because sometimes we got less information because of the language barrier, because of the rush from the ground floor, for instance. And we also have the third layer, the fourth layers at outpatient clinic counters to recheck again. And the fifth layer is in the medical doctor's room. So every one of us need to be strict to the screening protocol. There's no shortcuts, and that is not blame in our organization culture, because sometimes we could hardly get full information from just one setting on the ground floor. So everyone, according to the 5 layers of the screening protocol, they work pretty much hands on hands and sharing information from checkpoint 1, 2, 3, 4, and 5. And nowadays, as the situation change, there are right now 4 big clusters globally, not only China, Middle East, Europe, and US. So it is a time where we totally detach all the service for fever and cough and cold to be outside of that particular clinic building. So again, that particular clinic building screen all the countries related to the symptoms of the patients. So screening for me and for Bamrungrad is very crucial, very critical.
Thank you for sharing that, Dr. Korpong. And Dr. Sho, can you explain about Seoul National?
As you know, the international program of our hospital is a part of a large general hospital, so it's somewhat different. And as Dr. Korpong mentioned, the incidence of MERS in 2015 is kind of a mixed blessing for us. Since that outbreak in 2015, where we lost about 38 patients with the patient population about 180 or so, the government of Korea, the designated number of institutions and financially supported to build this kind of intensive care unit separate from usual hospital intensive care area on top of the emergency room, and that was built a couple of years ago. So that unit was not being used, frequently over the last 2 years, but it is a big asset for this type of outbreak. As you know, the epidemiological problem of Korea case of COVID-19 was somewhat different in the sense at the end of February, one church group in city of Daegu caused a major outbreak of currently about 80% of the COVID-19 cases came from that city and that province. And so, yes, the medical institutions in that city and in the provinces were overwhelmed by this large number of patients. But in a relative sense, the major institutions in Seoul or the area were kind of even distribution of the patient volumes over the last couple of months. And for international program, because of that incident at the end of February, we had substantial drop in patients from that incident due to the travel restriction from countries like Kazakhstan, Russia, UAE, and so forth. So we had substantial decrease. So we sent out, we continued to function, getting, referrals and treatment plans. Actually, patient didn't come, but we continued to service those consultations as best as we can. And we sent out, the appropriate letters to the embassies and, referral centers and so forth. The different from the MERS era and now are another, set of a screening before the international patient come into the hospital complex. Our employees meet them and help them translate with the questionnaire and so forth before entering the triage centers. So that's basically the difference. As you know, the screening criteria for MERS and this COVID-19 is almost same: fever, travel histories, and respiratory symptoms and so forth. And go from there. If there are any suspicious cases, they will contact the ID and and so forth. And as you know, Korea is well equipped with all the IT technologies and so forth. I think one of the difficulty of the policymakers and administrators and so forth will be the basic principle of this isolation and so forth is somewhat related with limitation of a patient's own freedom of movement and so forth. That's the agony the policymakers has been through. As you know, Korea has never been prohibited any entrance of the patients from outside country, even now, even though the other part of the countries like Emirates or Kazakhstan sort of prohibited Korean people coming into their countries. So right now, every travelers coming from Europe are screened and undergoing this COVID-19 test at the airport right now. And there's about 1,500 influx of patients every day, which is a substantial decrease in Incheon airport. But everybody, I think very soon the US people coming into South Korea will be screened by the test. This is huge economic impact in terms of cost of this test and so forth, isolation and so forth. And this is the agony of the government, actually, that have to digest these issues. So we'll see what happens.
Well, thank you for sharing that. These are very, very challenging and tough decisions that all layers are being faced with. So our next subject deals with capacity challenges or the need to prioritize beds for patients with COVID-19. If you could please share any communication strategies used to relay this message to medical travel patients, or if you had to have them cancel their trips, or or any plans on how your organization will connect with medical travel patients to reschedule, if at all, if you're thinking of that right now. And Dr. Korpon, maybe we could start with you this time.
Yes, thank you, Karen. As Bumrungrad, we have around 1/3 of our patients are international patients. I think it's a good mixture by having international patients, local Thai patients, and expats. It's a good mixture for a lot of things. Once we used to have the Thailand crisis, the Thai people drops or expat drops, the other segment complement each other. So having the three pieces of patient segments complement each other quite well. For this time, the medical tourism has been affected a lot, as I would say. The first impact is from China. Even if we have not too many patients coming from China, but after the Middle East cluster start to increase to be one of the hotspots, we got two impacts. Not only patients from the Middle East, but also some countries try to get their people back to their home country. So that is something that our top management needs to be very careful on how could we maintain not only the business but also the relationship and the trust. So trust is something that we try very hard to educate. It is not about COVID-19 disease spreading methodology, whatever, but would you trust at our Bumrungrad? Bumrungrad use a strategy on medical tourism by having appointed representative offices. We have more than 60 representative offices globally. So that is the very critical point. That is something that we carefully select who shall be Bumrungrad partners globally. With that trustable partners, it is very easy to move on. So once we got the trustable partners, meaning that we are on the same page on philosophy, mission, vision, that is something that we are very careful on how we select partners in each country. From those particular partners, we truly engage them into the hospital protocols. They know what we are doing. They know what is the screening questionnaire is. They work on that, the pre-screening questionnaire, and send to Bumrungrad. And we work hands in hand together on every particular cases. We also educate them about the patient journey so they can close their eyes and they know exactly what will happen next once we accept the patient, before the patient arrival and after the patient discharge from the hospital and leaving Thailand. So that is very critical that I would like to share is we must strengthen our relationship with our partners from overseas by selecting the right strategic partners, engaging them with all the programs involved, infectious program, the screening protocol, and whatsoever. Talking about the protocol, we need to get them trust the hospital, the screening. We should bring them in to experience what exactly your patient will experience. So before the big pandemic happened, we at Bumrungrad, we called them in early this year to experience what is going on in Bumrungrad because some representative office are new to Bumrungrad. So we bring them in and then screen them and educate them and walk them through every journey that your patient will experience. And last but not least is the open for feedback. Working as a team, Bumrungrad and our partner needs to be able to feedback each other what exactly that the patient needs, what exactly the service that they are looking for. I think everyone agree upon the ultimate goal of the medical tourism program or is the looking for a better healthcare services. So this is something that we need to be able to identify. The medical travel program for Myanmar patients might not be the same as the Middle East patients, might not be the same as the Chinese patients, and their culture, their belief, and a lot of things come into one that we need to know exactly the patient insights so that we can deliver whatever they need.
Well, thank you, Dr. Korpang. I think bringing up issues such as trust and assuring the patient and confidence in the organization. At this time, I think it's very important to emphasize some of those issues because we sometimes are just thinking of the more strident clinical issues that need to be managed. So it's important to also think of the patient experience and how we assure patients and try to gain their trust in the organization. Dr. Sho, would you care to share Seoul National experience on this issue?
I think in addition to the measures we have taken there are two components I want to just mention is activation of sort of a telemedicine in the sense the pre-existing patients who have chronic condition or cancer treatment or whatever. We are more actively utilizing sort of a telemedicine prescription and the instruction from the proper professors who have been taking care of these patients, giving proper refill or whatever prescriptions or tests, follow-up CT scans, which ordinarily be done at our campus with the follow-up visits at our campus. It cannot be done at this point. So we are more actively mobilizing those. So coordinators and the translators and the physicians go to orthopedic surgeons clinic and give the feedback and get the feedback back to the patients and so forth. And the other system, very recently, last week, we embarked on as an institution is sort of a community isolation centers. So these are the facility used by, say, Samsung training education centers, or big industries have their own employee training centers, which is like a hotel type of facility with so we are dispatching medical staffs, nurses, radiology technicians to that facility. And then we have a control center down in our auditorium, but staffed with the physicians, nurses, and administrators. And through the web, the health information technology, those people who dispatched, drafted to the community health centers, which basically take care of positive but minimally symptomatic patients isolated there, report their health conditions, viral, whatever, and give feedback to the control towers in our institutions, and appropriately triage when after they turn out to be negative, they go home. If there's any worsening of symptoms, they will be readmitted or be admitted to whatever necessary. So, and some of the foreign patients, Europe, turn out to be positive with minimum symptoms will be isolated there. That the community, the terminology varies because it's got new things, community isolation centers, and then monitored by our staffs and the triage as necessary depending on how their symptom and signs evolve over the next few weeks. So that's two additional projects we are doing in addition to the on-campus management.
No, thank you very much for sharing that. And Dr. Hassan?
Karen, I've been enjoying listening to my panelists. Can you repeat the question again, please? Do you mind?
Sure. It's really talking about, and you might not have reached this yet, but dealing with capacity challenges or the need to prioritize beds for COVID-19 patients. So are you using any communication strategies? Is there anything unique that you're doing at this time to reach out to patients who might have been scheduled to come to Cedars-Sinai, and how are you managing that?
Yeah, we are definitely in that now. I think it's probably we're in the thick of that right now, if you will. And for us, we're and like the other hospitals from my colleagues, we're really a referral center for the world and many of some of the really complex diseases that we take care of. And so, it's led to a lot of tough questions, amongst the chairs, amongst the hospital leadership about, who needs to be, what is truly elective, what is urgent, what is not. And of course, you start getting into advanced cancer care, and the timing of that, sometimes weeks make a huge difference. And if the patients can't receive care in their country, you're almost cutting off your nose to spite your face, if you will. We are committed to our community, and we have to first and foremost provide safety for all our patients and for our providers and the community. But in the midst of that, it's almost a case-by-case triaging basis because we have patients who are that come to us for heart valves, and they don't have access to some of the more complicated, even if they're getting TAVRs around the world, some of the most complicated cases get referred to, our lead, Dr. Makar, who's really one of the world's leaders in this, as just a simple example. And I mentioned cancer. I think we get a decent amount of we have the largest heart transplant program in the world, and that heart transplant is the tip of the iceberg for heart failure. And there's so many patients here that are come to us ultimately hoping for heart transplant, but we're managing their heart failure. And so these are complex conditions that you can't draw a clear line on. And so it really is, again, like as I mentioned, a case-by-case basis. Certainly the hospital as a whole has reallocated and shifted. We have a lot of resources. We are the largest hospital in the Western United States, but we're also at capacity every day. And so this pandemic comes at a time when historically Cedars-Sinai has never, I mean, as opposed to my, I come from Johns Hopkins, obviously spent most of my career and canceling elective cases obviously has changed over the years, but is a reality day by day. Here, it's a new thing for Cedars. It is unthinkable almost in our organization to cancel someone's surgery due to capacity. And so that we're at the pinnacle of that, and all of a sudden here comes this pandemic. And so we've thankfully, I think the patients that are traveling do understand. Some of them are forced to understand by being constrained and by either their country or our country and inability to arrive here. Some of them obviously appropriately have fear of traveling and can wait, and others just really need to get here. So it's a mixture, and I think our hospital is also, as I mentioned earlier, internally, we've created a separate area for the patients who are positive or suspected. We have a separate ICU for COVID-19 patients that's been set up now. We try to minimize movement, as I mentioned, through these using iPads and consulting into the ICU with the physicians there about whether or not a patient needs to be triaged to the ICU or needs to receive critical care. So I think that's an important issue internal to the hospital as well. I think in summary, what I'd like to highlight is that there aren't clear sort of boundaries around this, and we do have to be somewhat nimble, appreciating the fact that ultimately the best treatment is for everyone just to, as one of our healthcare leaders mentioned recently, just wave a wand and everyone stops movement in their place for 14 days. And this pandemic will come to a halt. And so we can't do that, but we want to get as close to that as possible and to try to defeat this pandemic.
Well, you bring up a very important point, and one that I was actually going to go into the next question. So maybe it really overlaps. It's really related. And that is, what do we do with the consequences to those critical patients who are, who need something very specific, or they might not be able to survive or have the quality of life, such as the cancer patients or someone who might have a special eye procedure. And please, all of the panelists are welcome to respond to this. So if you know that they're not able to come, say, into the US at this point in time, if they're coming from Europe, are you able to recommend another organization, or how do hospitals, what are hospitals doing now? Are we trying to kind of partner with other organizations maybe to get them treatment in a country where they might be able to travel to? Or I know that it's very difficult issues, but I'm just wondering how hospitals are managing that, and doctors.
Well, it's a great question, and I hope everyone at some level is doing their best to put the patient at the center of this. And actually, that's our philosophy always. And so I'm going to mix I think here, we are developing a sort of a global network through affiliations and through collaborations. We're early in that stage. I come from, as I mentioned before, from Johns Hopkins. That is, one of the early pioneers of creating this global system or network of hospitals. And the argument always was that, the only way to really improve healthcare is to create standards and processes. And the next level of that is actually a network to be able to refer patients within one system, and where you can share records, share everything. So this is a philosophy that we aspire to. And I think in acute times like this, that philosophy is we stick to that philosophy. Thankfully, I would say about half of our patients, give or take, come through referral channels or pipelines, and the other half come to us because they're reaching out to Cedars either because of our expert care or either because we're in Los Angeles and that's where they want to be. But through those referral channels, I mean, I think an example would be the Abu Dhabi Department of Health and IPC. I mean, I give and a credit to Hind Zahabi, who's leading that IPC office, and he really was one of the first to say, we're going to stop travel. This is a difficult decision. It's never happened in the history of this whole business that we're in, which is taking care of some of these complex patients that come to the United States for care. But that was for the safety of the patients, safety of their community, and the safety of our community. And so we're working with them, to try to link remote consultations in a systematic way. The same thing with, we do have partners and colleagues in China in a similar fashion that we're trying to do that. We're not into, we obviously have a telemedicine program as a remote consultation, which is sort of the base of, I would say, telemedicine for anyone who reaches out to us. But we're moving forward quickly into taking care of these patients remotely. And I think part of that is being able to be an added knowledge to those physicians in those countries or those caregivers. So in that way, we may not necessarily be moving them to other hospitals or suggesting, but that we're just giving them an extra input that's going to help them get care where they are and to stay in place. So, I mean, I think it's a multi-pronged and multiple approach, but the philosophy stays the same: is put the patient at the center. Let's get them the best care that they can wherever they are.
Right. Well, thank you, Dr. Hassan. And Dr. Korpan or Dr. Shah, would you like to comment on this issue? It sounds like both of your countries are receiving patients, so you might not have this challenge, but I just wondered how you might handle it.
Well, I think as Dr. Hassan mentioned, that nothing is written in stone at this point, and we have to play by each individual patient. And as far as patients coming from GCC area, as you know, we have a separate institution in Ras Al Khaimah in United Arab Emirates, and we use that institution as our branch hospitals, and if there's patient follow-up and so forth. And as far as the patient coming from Central Asia and so forth, we have a physician in our staff who is familiar with that country, the medical systems and Russian medical care system, and some of these patients can be referred to the cancer centers in forgot the name of the city, just blanked out, but city in the Kazakhstan or major cancer centers, or refer to them as necessary. And also mobilization of our telemedicine, so we fill up the prescription here in Seoul and deliver to the patient through the embassy, and the like Kazakhstan embassy has been very helpful to that capacity.
Okay, that's very interesting. That's a good strategy. Yes, Dr. Korpan, do you have any?
Yes, may I have 2 points to address here. One is we have 3 layers of networking in the country at the moment. Bon Murad Hospital itself has more than 50 Bon Murad Health Network hospital, and we are now working close together in terms of knowledge sharing. I won't get into detail that much, but as a frontier in Thailand private healthcare institution, the benefit of having our own Bon Murad Health Network is supporting each other. The second layer is we have Thailand Private Hospital Association. Mm-hmm. At the moment, we work close together under the TPA, Thailand Private Healthcare Hospital Association. In all means, we have a regular meeting monthly, we have sharing information, and we have sharing knowledge. And the third circle is the Minister of Public Health. Over the last couple of weeks, the Minister of Public Health invites all the stakeholders, the public sector and the private sector, work on the same table, sharing resources, is the ultimate goal. Right now at the Ministry of Public Health, they have listed numbers of how many AIR rooms in the whole country, how many infectious specialist doctors, how many PPE do you have, and all those. The master list of all resources that the country might need. That is something that I would like to share to you, that this helped us a lot to plan ahead, to work close together among our own network, among our private hospital, and at the national level. The second part, talking about the critical treatment for specific patient groups, for instance, oncology, dialysis, transplant, we assign the patient-assisted center team. This is a new team established at Bamungrat since the beginning of the year. This team has been assigned to take care of all perspectives of the patient needs. This team, we work closely with that particular unit, for instance, oncology. And it is the right time for everyone in healthcare organization to redesign their service and processes using technology. For instance, we right now have the home quarantine protocols for the patient who have a home quarantine at home. We have working very hard with our partners like hotels, apartments, that help the medical travel patients to do the quarantine in the hotels for 14 days.
Okay.
And also after that, we do the COVID test after that particular 14-day period. And then now they can access into the regular service. That is a lot of things that we learn from GHA requirements, that this is something along the patient journey, that every time GHA coming to the hospital, they're looking to hear and see those a little piece of everything.
Well, thank you for sharing that. And I wondered if you were requiring that 14-day quarantine. So thank you for highlighting that. And each of you has mentioned in a little way telehealth and, you know, applying that more directly at this point in time. And obviously it has advantages both to the clinicians and protecting them as well as to patients, where they don't have to go out of the house, or there's less exposure. Even my daughter, who works in a dermatology, she's a mid-level provider, and they have just recently instituted telehealth because patients feel more comfortable being able to show a rash through telehealth. And I wondered if there's any other examples you would like to provide, or in Bumagrat, I know you also have the medication tourism that was launched last year, I believe, where patients can access specialized pharmaceuticals, vaccines, and specialty treatments. And Dr. Shah, when you were mentioning filling the medications and having the embassy delivered, it brought that to mind. So I'm just wondering, those are very creative applications. Maybe you could talk a little bit about those. And Dr. Korpong, maybe we could start with you on the medication and talk about that.
The transformation start over the last 4 to 5 years, when we try very hard to adopt the new technology, the roadmap for digital transformation and also clinical transformation. One thing that we know, that we are not the expert in the area. We are lucky enough for this year that we have our new chief marketing technology officer, chief martech, with us. So he's the one who changed a lot of mindset, point of view, and process of work. We have been working with him for a period of time, and we changed a lot of what we are doing. Regarding what Karen just mentioned, we call at-home project. Bamungrat at home is something that we use mobile applications that the patient can easily access into the regular services. Especially during the COVID-19, the demand is going up very high. We try you would be amazed that one of the application lovers is our senior doctors. It is something that we learned that age is not the issue. Sometimes we think that the young generation, the young doctor are very keen and very tech savvy. But you know what? Our endocrinologist, she is over 60 years old. She loves that particular tools that we provide to her. And this kind of thing is not only just the doctor to the patient. We just had a good experience. We have family meeting online. The daughter is at the office, the mother is at home, and the doctor is at Bandung Rat. So this is very fascinating situation that we share among our medical staff, that you can not only talk to the to your patient, but the whole family. So this is one thing that we start for many months. And later on, during the COVID-19, we kick off the at-home project. We would be able to knock on your doors, do the blood testing for diabetic patient, and we can deliver medicine back to your home. And the third thing is what we learned from our chief Martech is right now we are working on the e-commerce, the online product and service that we put on e-commerce platform. This is something that helps us for everyone, not only in the country, but outside Thailand, that for instance, refill medication or vitamin supplement refill, for instance. Those things are very new for us, but if we are open to learn and we not just put that particular issue as a project, but try hard to redesign our core process of work. This is something that is critical from our experience over the last years.
Well, thank you very much for sharing that. And Dr. Sho or Dr. Hassan, any other comments on this topic?
For the medical travelers, for us, the telemedicine is more focused on pre-existing patients, and on new patients, it is not really truly telemedicine, but in some consultation type of process. Especially right at this time, we are focusing on the pre-existing patients, service to them, but also it is largely depending on the the attending physicians who have been following these patients, and they have to be comfortable with whatever prescription they provide, to knowing the condition of the patients. So, unfortunately, right at this time, we still have to rely on the individual doctor's judgment, whether it is appropriate to prescribe, even those patients who were known to them. And I think also there are legal issues, concerns posed by the Ministry of Health and so forth. And there are certain criteria that has to be met to the eyes of government with, how actively employ this technology at this time. So one of the criteria is difficult traveler is one of the criteria. So I guess this fit for the current medical travelers in this time. So that's where we stand in our institution for that.
Oh, well, thank you very much. And Dr. Hassan, you brought this up, but I don't know if you have any other remarks you would like to.
This sure feels like a tipping point, and you can imagine it being the focus of the next Malcolm Gladwell book, or someone who's a wannabe Malcolm Gladwell. I mean, this is in healthcare. It sure feels like finally, something like this is going to push the whole industry forward. In the United States right now, I think it's been, some of it is finding its place, has been finding its place, the use of telemedicine, whether it's rural areas or whether it's select service lines like stroke or neuro, which makes obvious sense and they flourish. I think right now the CMS has relaxed the guidelines for billing, so that is having a huge impact because it sort of unlocks some of the complexities of, you know, patients are being treated as if they're coming into the office, and so they can be at home and the doctors are at home and providing some of that service. And in fact, for us, it's had an impact because we have patients who are here in country, whether they're here for a long time getting cancer treatment or transplants, or they happen to arrive recently and they can't come to the hospital, then they're getting their consultations remotely. And quite frankly, many of them like that for follow-ups in certain conditions. So, you know, we're trying to figure out what that, you know, still what that means to regulate all the different billing processes. But right now, at least we're fortunate enough to be able to just move forward with that and not have to worry about that. So I mean, this certainly feels like a tipping point, and I think those who've sort of worked really hard, have left their corporate jobs to build telemedicine startups, and you know, it's been a slow grind. Maybe this is their moment to shine and to show, because there's no doubt that this is going to be a huge added benefit for all of society. I think to be able to receive care in a structured way without having to be face to face in contact with the physician. We know we can do it, and we need to apply it more.
Yeah, no, thank you. I think using the term tipping point, it's a very apt one right now as we're facing this challenge and crisis. It certainly is a utility that is of high value to many, many folks, both the patients and the providers. Let's talk a little bit about supply chain disruption. And obviously, we've heard here in the United States about shortages of PPE. One of the GHA standards certainly relates to supply chain. If a patient is traveling for hip replacement and there's a medical device, you know, do you have that in place prior to the patient leaving, things of that nature. Just wondering if you have faced challenges with respect to supply chain during this particular challenge. Dr. Shah, maybe we could start with you.
Yeah, in the past, you know, the hospital administration has also, you know, duty of this maintaining supplies and so forth. Since the outbreak of COVID-19, the Korean government, and there are basically two additional support from the government side. Number one is KCDC, and number two is the Ministry of Health. They have have assisted monetarily as well as systematically support A, tertiary institution, and B, there are about 300 some designated hospital function as center of care for COVID-19. They have been helping these institutions with extra supply of, you know, whatever protective gear or that kind of things. So that has been very helpful in terms of medical staff protection as well as patient care. And I did mention at the beginning, but basically every individual entering the hospital, whether that's a patient or family or the hospital employee, they have been wearing masks very religiously since the beginning of the year, or even from the December last year, very religious wearing. And also, you know, you're getting every day from questionnaire from the employee health centers to try to detect any changes in health condition of the employees every day through cell phones and so forth. So so that's the support as far as the supply chain is concerned. And, you know, any the suspected contacts, they will be isolated, employees will be isolated, and cost of the tests and et cetera is covered by the National Health Insurance of Korea. So
okay, thank you. Dr. Hassan, on supply chain, I don't know if you have any comments you'd like to share.
Well, I think it's been an interesting time. You know, I'll just give, you know, my perspective. We started with cries for help from our partners in China going back to, you know, early February, and that was a journey, an interesting one here, because there were two things that turned out. I'm saying this not only for our hospital, but talking to my peers, it was kind of the same from the major U.S. hospitals. We'd love to help, scrambling, trying to collect supplies, but then you had to battle sort of hospital operational leaders who are saying, no, we don't have enough ourselves. We need to keep it in case it comes here, which had tremendous foresight, actually. And those of us saying, come on, are you kidding me? Like, these people, we need to send it to them and show solidarity and really try and help. We'll worry about us later. And then if you get through that, then you had no way to get it there because the flights were shut down and it was very difficult to figure out how to get the equipment. So, and then I think, and I'm just so amazed by the tremendous response. I know they took a lot of heat, the government and non-government entities in China, but their abilities were tremendous, really. And so they managed the situation in whatever way they did, and I don't know details. Then you fast forward about a month or so, and then now we're getting a flood, literally a flood of emails again and phone calls, what have you, from our Chinese colleagues, this time offering help. So the complete flip side, and we're trying to figure out, okay, just to sort that out, our supply chain are getting a lot of these requests and trying to figure out, okay, who, which are as legit, which is most legitimate, how do we really do this and create a global supply chain? So in this little story I'm telling is really where we're all at, quite frankly, is we're really not necessarily prepared for this, how do you deal with this? And we're going to learn from it, of course, once we get on the other side of this.
Right. Dr. Korpa, anything to share?
A couple of things. One is we have the more than one vendor strategies. In each particular items, we will not have only one vendors in our hands. So this is very important. For instance, right now in Thailand, we are looking for PPE. We are fighting for PPE. And that is something that helped Bumrungrad to come this far. Over the last 3 months, we could be able to say that we still be able to survive for the next 3 months. So we have more than one vendors. We have more than one sources of supplies. The second one is as a big institution, we have regular review the preferred vendors. So that is something that we learn from not only GHA but JCI and local hospital accreditation, that what should be the criteria to be the preferred vendors. So from that one, we can carefully select, evaluate them, and then work with them, feedback with them. Talking about the stockpile, as I mentioned earlier, the Thailand Private Hospital Association helped that much to support each other and negotiate with the ministry level to looking for supply of PPE and medications. Last but not least, just launched 2 years ago in Brisbane, Australia, is the requirements from HIMSS. HIMSS just refer to a lot of adoption model. The latest one is the supply chain, which would be able to help the hospital to trace, especially the devices, the new medical technology, especially on the IT security point of view. So if we are talking about the supply chain, it should not only be just medications, PPE, but also the technology itself. You learn a lot of hospital information system being hacked here and there, and some of those are from infusion pumps, medical devices. That is something that HIMSS, as I be part of the HIMSS Asia Pacific as the advisor and also organizing committee for the regional conference for many years. It is quite new for every one of us. If we are talking about the digital transformation, you should not forget about the hacking from those supply chain related to your device or your machine.
Yes, no, those are very good points. And I thank you and all of you for sharing your perspectives, because this is certainly a very critical thing. It usually can be hidden, but we really need to be paying attention to supply chain. And our last topic, as we move, we're getting closer to the hour. I'd like to focus on the future of medical travel. We certainly know that COVID-19 is not done and it won't be the last pandemic. And while China, South Korea, Singapore, and Taiwan have largely turned it back, it certainly continues to ravage many countries, including those in the EU and the United States, as well as many others. It poses a serious threat to human safety and is disrupting both our social and economic norms and impacting a devastating blow to industries not only involved in healthcare, but far beyond. We also know that most healthcare organizations and governments are focused on this pandemic. But for those involved in medical travel, you may also want to be thinking now about the future and what changes will result as both healthcare and society change in ways that we cannot fully anticipate. I do think this pandemic, and Dr. Hassan, you used the word tipping point. I do think the pandemic will result in changes to our society in ways that we might not realize yet. For example, as we've talked, there certainly probably will be a greater acceptance and greater utilization of telehealth. And for distance and online learning, many schools are closed, and obviously that will be a more accepted practice as well. And telecommuting, which as industries are shutting down, so many organizations have staff working from home through this difficult time. It certainly brings down the need necessarily, or as a greater need for bricks and mortar, and certainly with lower cost. So as medical travel is potentially slowing down or at a standstill in some organizations, as many other industries currently are, we also know from history that medical tourism and medical travel returned and grew stronger even after serious challenges such as MERS and the swine flu and SARS. We also learned many lessons from those experiences. And we do need to remember, as we've talked about today, the many challenges whose elective surgeries and treatments are being delayed as a result of COVID-19. And they are still suffering and they will want treatment. And what of the patients who still will not be able to afford care in their home countries, or need treatments that are not available to them there, or seek a higher level of care? These drivers are not going to go away overnight, and in fact may escalate as economic pressures increase on the cost of healthcare in some locations. It may require a more creative outreach to patients, to these types of patients who are willing to travel, to their governments and their employers and their insurers, and special assurances. And Dr. Korpong, you talked about trust. How do we convey trust in your organizations and trust in they might have fear of traveling now as far as distances for care. So we all might need to revise our business plans, our strategies, but it certainly will make our sustainability in the future, I think, a greater one, and will bring us together closer as globalization. So I'd like to ask our panelists if you have any thoughts on the future and what we might be able to be doing now as we contemplate that future, because we know it will come back. People will still want to travel for care. People will want to see specialists, will seek higher quality, lower cost, quicker access. And Dr. Shah, I'll start with you. If you have any thoughts on what we might be considering as we're in this crisis mode now, but are there ways we might want to operate differently as we move into the future?
I think two things should happen. Number one is, as Dr. San mentioned, in order to activate telemedicine, a very active discussion has to happen between the policymakers, insurance industries, legal community concerning their liability and so forth. And this has to be actively started right now, actually, in order to prepare for international healthcare and cost containment, and because the healthcare disparity will continue whatever part, whether this is a disease disparity or technical disparity of healthcare in different part of the world, will continue, and then there will be a population of patients needs to be treated in foreign countries. If you consider focus of this issue is the patient from different part of the world. So I strongly believe there should be a very active discussion should happen between policymakers in the insurance industries and legal community, how we digest these issues first. Number two, for the frontline workers, like the people who are working, like the three of us here in the international, the healthcare sectors, I think we should develop renewal or the act on the proper mitigation strategy for medical travelers to prevent the COVID-19 issues in upcoming years. I'm sure there should be some additional processes we have to develop, because certainly at some point there will be reactivation of medical travel program. Hopefully. And as you can see, this virus, whatever, will subside by some way, because with the proper epidemiologic measures or medical care, I do believe there will be subside in a fairly near future. So that's all I can say. There are twofold activities should happen.
No, thank you very much for that. We're starting an action plan then. Dr. Hassan?
Well, I mean, I think, no doubt the pillars of why patients travel, and I think you kind of captured it, Karen, which is, in whatever order you want to put them, quality, access, and costs are not going to go away with this or not going to be cured, or that's not going to go away through this pandemic. So I do think patients traveling for care has been around since as far as history is recorded, probably. And I think those traveling to seek new knowledge and skills have also existed throughout humanity, and that's not going to go away. We know that. But undoubtedly, it's very hard to imagine we won't come out of this with some different perspectives on things. And I think my optimistic side for the philosophies I alluded to earlier is that we do put the patient at the center. I think the importance of global collaborations from institutions like the ones on this panel, and actually have relationships. I have relationships with leaders from both, and we've in some ways created some type of partnerships with both, are so critically important. And I think we need to create standards of care and facilitate a sharing of knowledge, and then that inspires telemedicine in the real way, I think, and remote training and education. So how we do it is going to maybe change the vehicle, the medium, but I think the concept is going to remain the same, that healthcare is as much global as it is local.
Thank you, Dr. Hassan. Very, very good. Dr. Korpan, welcome your thoughts on this.
Yeah, my turn. We all are in the service industry, and I myself believe in the power of the people. Once we get away from the COVID-19, it would reflect how we take care of our people. The team spirit, the team motivation is something that needs in every army to fight with enemy, and this time is the virus. The team spirit is something that could be something that technology could not provide. So we pretty much focus on our people. That is the center of everything. The second issue is how we respond to external environment or things happening. I mean, agility of the organization. Agility is our Bumrungrad DNA at the moment. So we again need to review, relook on how fast we respond to situation. Could we be better than before? Could we be faster than before? Could we be more effective and efficient than before. That is the second issue. The third one is how would we proactive? How would we better prepare for the next outbreak, the next issues?
Yes. Lessons learned, yes.
Correct. So this is something that I would like to emphasize, the issue of enterprise risk management. It is not about the clinical risk anymore. It is about the whole corporate-wide risk management. So these emerging diseases is one. As I mentioned earlier, World Economic Forum mentioned this. And the second issue that World Economic Forum also mentioned that might be applicable for healthcare industry is the cyber threat. So this is another issue that if right now at Bumrungrad we adopt the principle of enterprise risk management into the hospital. The fourth one is the how we adapt technology to transform our safety programs, to transform our care processes, to transform our support services like training, learning, or back office stuff. So this is something that we need to relook. That is something that not far away, but it is in here. I think we could learn a lot from South Korea because they are very keen on the technology part, mobile and everything. And last but not least, that I would like to mention is we need to have friends. Today, I would be able to meet new friends from Cedar Sinai and South Korea. Karen is our old friends. So we learn from friends is something that is very important. And thank you to GHA to be our strategic partner today.
Well, thank you all. I think this has been a very, very interesting and really compelling panel. You've been very, very generous in your sharing of your experiences. And I'd like to also have a message to those who are listening today and state that GHA would really like to, we welcome your thoughts on these types of webinars and how we might be able to think through these issues and explore together how we might make medical travel stronger as it reemerges once again after this pandemic. We do care about you. I think all of our panelists have talked about the power of people and trust and friendship. And we know we're in this together, and together we can figure it out. So please let us know if you would like to be part of this discussion and this global collaboration that I think possibly we're creating right now, and to share our best practices, and or if you'd like to participate in future webinars, please contact me. If you would like to participate, we would, and also just if you'd like to shoot off an email, we'll certainly share it with those who are interested. It is now my pleasure to welcome and introduce Dr. John Louis Lucas, who is Chief Executive Officer of City International Hospital in Ho Chi Minh City, Vietnam. Dr. Lucas, perhaps you can begin by providing an overview of the mitigating strategies Vietnam initiated to minimize the spread and impact of COVID-19, as well as actions that you have implemented within City International Hospital.
Yes, thank you for that introduction. I will just talk about Vietnam. Vietnam had a lot of experience with SARS 15 years ago, so they have quite a robust public health structure, and they've been extremely proactive. Now their main focus has been containment, so that involves tracing contacts. All of our cases so far have been foreign. We have not had any community transmission that's been at least validated through testing. So it appears the containment strategy has been working, although we're starting to see more cases. So I think we'll hit a tipping point where we will get community transmission and have to change from containment to mitigation. So, but the containment has been canceling flights, closing the border with China, now not granting visas to any foreigners coming into the country, and the use of quarantine. The mitigation focus is really social distancing, and closing public areas, closing bars and restaurants, closing schools, and really emphasizing personal hygiene. In Asia, there's a real emphasis on wearing masks, even though in the U.S. that's been controversial, and the government has asked people not to wear masks unless they're infected. Whereas here, it's mandatory that everybody wear a mask.
That's impressive. Yes, very interesting.
Yeah, and I'm told that harkens back to the many epidemics in the past. So it's very much a part of the culture. Whenever there's an epidemic, everybody goes to wearing masks. The population seemed to self-isolate and stop going into stores and facilities 6 weeks ago, well before we had anything more than 15 or 16 cases, and there were no more cases for 3 weeks, but they started accruing again about 10 days ago. So I think the level of containment and mitigation is getting more aggressive now.
Mm-hmm.
But so far we only have 60 cases. The one thing that's problematic is that we don't have much testing. So
Mm-hmm.
similar to the U.S. experience, there's been very tight control of tests. So those of us that are in clinics and facilities can't do any testing. It all has to be referred back to a limited number of laboratories. If people are test positive currently, again, with very few cases, they have to go to the public facilities. Private hospitals really are not allowed to take in COVID cases. So if we happen to have somebody that we put under investigation and they test positive on the screening, and even though testing is pending,
Right.
with the PCR tests, we still have to transfer them to a number of very specific hospitals.
I see.
Quarantine is very aggressively used. There has not been home quarantine yet. So in Korea, for example, where they've had a lot of cases, they put people on with mild disease. They did this in China as well. They have them go home rather than putting them in what we call quarantine camps. But still, quarantine camps have been what we've done here. But unfortunately, there are thousands of people in them, and they're tending to fill up. So I think we'll have to see a change in the strategy to probably home isolation. Now, that's problematic for medical travelers or tourists. They really would have to do that in hotels. So that's going to be quite challenging. If you're a tourist that gets caught in this situation, then you don't have a place to shelter that's very accessible to you. So there's probably going to be a number of hotels designated as quarantine centers where people can go. So we'll need to have that expansion very quickly here because the current centers are all full. There are 8 or 10 of them here in Ho Chi Minh City, and they're at peak capacity now.
And those were for those who had tested positive but are mild cases, or?
Quarantine is anybody. So you have something called F1, and then you have F2, and then F3 and F4. So it's classic epidemiology. The F1s are people that either have that are COVID positive, or they've been in intimate contact with somebody that's COVID positive, say a family member. They all go into mandatory quarantine. They go into the hospital, those people. The F1s don't go to the quarantine centers. The F2s are more distant contacts. And as you branch down, you know, secondary, tertiary, quaternary contacts. So the secondary and tertiary, they go to the quarantine camp facility, which really isn't medical service oriented. It's purely separating those people who are asymptomatic.
I see.
Yeah.
I see what you're saying. Okay.
Yeah.
Thank you for that explanation, Dr. Lucas. Do you anticipate for a private hospital, if Vietnam does need excess capacity other than the public hospitals, that private hospitals such as City International Hospital would step in and be a provider for COVID-19 patients?
Yes, we have to go through a process to be certified to provide to these patients, to these COVID patients. So the Department of Health for Ho Chi Minh City has a list of hospitals, and they're starting to add private hospitals, international hospitals. But we have to go through a process. We have to be inspected to make sure, you know, that we have the competency to take care of this type of patient, this highly infectious patient, and, you know, where we can make sure our staff can protect themselves and are familiar with procedures and PPE. So we expect we will be evaluated next week for that.
I see.
Yeah, we have a 20-bed unit.
No, please go on. Please go on.
We have a 20-bed unit, but we will need to have it licensed to take these patients in.
Okay.
And then, but the reason why they're doing that is to create more potential capacity should they need it.
Okay. And currently, what is happening to those patients who might need critical care, such as special surgeries, cardiac, oncology? Is that going on as normal?
It is going on as normal. In a crisis, for example, when you hear the story in Italy in particular, you have to appropriate a lot of the technology. For example, you turn your OT, you use the anesthesia machines as respirators. So in Italy, they created 20% additional ventilator capacity by using other sources such as anesthesia machines and other parts of the hospital, like the PACU and the operating theater recovery area. So there are ways to add more ventilators. So we expect that in order to do that, you would have to, if you're running a hospital, cancel all your elective surgeries. However, in Vietnam, there's not a need to do that because the patients do that themselves. Starting February 1st, our volume dropped in half. And so without any directive, the patients started not coming in. They're fearful of going into hospitals right now. So they're not following through with procedures as much. There are certain populations, obstetrics, where they still have to get the care, so they're coming in. But our elective procedures have pretty much dried up. We're doing very little right now, and it seems like the patients want to defer all that care until the epidemic is over.
Yes, I can understand the fear. We're seeing that likewise here in the United States. And what about communication with payers or suppliers? Have you had to do any anticipatory proactive outreach to these?
Yes, we
Significant-
certainly supply chain is critical. So we're reaching out to the vendor community and really trying to lock up as much as we can for our needs. Our goal is to have at least a month of consumables available, you know, and then having contingencies if we run through them more quickly. Same thing with pharmaceutical supplies. So yes, we're working very, very diligently to assure that we don't get cut off from anything. The risk in private hospitals is we have to use the same supply source as the public hospitals. The public hospitals will be given preference. So we'll be in the second tier for receiving resources. So that's going to be a challenge.
Absolutely.
So that's part of why we want to be certified as a treatment facility, so we don't get locked out of the supply chain.
Yes, I can understand that. And moving forward, thinking hopefully in the not too distant future where this crisis might be dissipated, do you envision special communications to medical travelers? How do you envision possibly your marketing or communication strategy as a way to reach out to patients who might be interested in coming to your facility, who might be foreign visitors? Obviously, they can't travel to Vietnam right now or might need to get a visa.
Yeah, there's the short-term aspect of that, and then the longer term. In the short term, it's, you know, we're compelled to, you know, we're using website and we're interacting with people on Facebook and social media, but we know we need to have a telehealth platform where we can provide consultations. So we're partnering with a company to do that, and then I'm enlisting our doctors to provide those services. I would say that in Asia, there's not the same comfort level with telehealth as you'd find in the U.S. You know, people are reluctant; they really want live visits. But I think with the epidemic now, people may shift because they're afraid to come in. If they can get care online or the information they need online, I think they will shift to that. So we'll offer some free services and we'll offer some fee services. We have it in English and Vietnamese so that, you know, most of the expat community is about 200,000 people in Vietnam. English is their lingua franca, so they will gravitate to an English language site like that. So we think that's a way to keep in communication with them and spend as much time as is needed to help people. But the purpose of the website is also to facilitate care coordination. Now, how to do the linkage with the insurance is the other question. So we need to reach out to them and have a partnership. In Vietnam, most of the insurance companies will not cover COVID. They, you know, so it's maybe 5% of them. So that's a big problem right now. Is they view it as a force majeure that they, you know, that they won't cover in their contracts. So that's going to be an interesting challenge to deal with. Whether that applies to the type of insurance international travelers have, you know, they have Blue Cross and Aetna, and you know, we have to see exactly what the you know, the large international insurance companies are willing to do, to see how they will want to deal with the claims that devolve from this. It's unclear, but we need to reach out to them and start talking to them and try to get some sense of what we can advise people to do and what their payers have agreed, you know, to do to pay their claims.
Yes, yes. Well, we certainly appreciate your participation on this webinar, Dr. Lucas, and your perceptions and insights into what is necessary in order to mitigate, contain, and hopefully
Yeah.
And we wish you guys.
Yeah, so I just will make one additional comment. I think that the group health framework is excellent. So we're looking longer term. We're hoping that we can build credibility and trust in the short term, but we think the challenge, business sustainability is going to be a big issue because of the drop off in business. So we hope longer term that we'll emerge on the other side of this as a stronger organization using more technology and, be formal active participants in the medical travel program. And, we're eager to work with you to develop that.
So, and finally, please, everyone, join me in thanking our esteemed panelists. You did a great job, and we certainly appreciate your sharing. Wish everyone to stay well and be well and stay safe. Thank you so much. Thank you, Dr. Carpon. Thank you so much.
Karen, what we were going to mention, we just had a few questions, if there's time, just a few minutes.
This is Bill Cook who is speaking. Yes.
Yes, I'm Bill here. We just had, we have several questions, but just getting a couple maybe. We have one one good one here from Maria Fernanda Valencia. She says, good morning. This is a question, how are you dealing with helping out patients to get back home? Early discharges, travel facilities are very restrictive at this time. How are you maintaining, how are you managing air ambulance patients in and out of your hospitals? For example, for patients who may have been in your hospital as the COVID crisis developed. So that's one question. I don't know if anyone on the panel wanted to.
Would one of the panelists like to respond to that if you have to handle early passage check?
The way it's a difficult question. Actually, we have a patient who has a VRE, needs to go back to Abu Dhabi, and commercial airlines is a carrier, VRE carrier, and we are trying to mobilize commercial plane, which was not successful, and we are now working on the mobilization of air ambulance. And luckily, there are several patients in South Korea who need to go back to the Abu Dhabi, and I think it's going to happen very shortly. But okay, it's a process, take time, because there are different perspectives from the air ambulance company and commercial airlines and so forth. So it's a process. Yes.
Other responders or?
I have three quick response. One is the fit to fly status of the patients. Number two is the COVID clearance test, because some country require to have the COVID testing that needs to be undetectable. And the last one is the protocol of each airports and each countries. So we need to learn from all stakeholders to be able to comply with all the requirements.
Thank you. And Bill, did you have another question?
We have another one here. I think this one may be available, well, is a lot in the news right now. It says, is it true in your experience of the panelists that some COVID-19 positive patients are not showing symptoms in your experience?
Well, I mean, I think it's definitely true. As you mentioned, Bill, that we know that about this virus, that there is a period of days where the patients are infectious and will not have symptoms. And so that, again, Korea has also been obviously in the news and getting a lot of credit for their ability to test quickly, rapidly the population. We're going to have a completely different experience, especially here in California, because we are taking the opposite, and maybe not by choice, but by circumstance, that we're only testing those patients who most critically need care, and requesting everyone else to basically not get tested and stay at home if and when they have symptoms. So, I think that's at the crux of this fight. If we had the time and proper abilities, we would test the entire population and quarantine those who are positive. But the reality is it's not that way.
Thank you, Dr. Lisa.
Even in Korea, these tests are done and patients are meeting certain criteria, so forth. And currently, the positivity rate is about 2.8%. Even those patient population who does have some symptoms. So they want to, if you want to expand the asymptomatic patients, I think eventually they are looking for the positivity rate around 1%. And as you know, US, the positive rate is about 10%, which means still there are a lot more population needs to be tested with this test, you know. So this is eye-opening. The difficulty of getting this test, even in Korea, there, you know, you have to meet certain criteria. So,
Yeah, I think we'll have to stop now because of the time.
Right.
Looking here with the, but just going to mention one question. You're asking if the webinar is going to be available, and it will be available on our website in a few days. So we'll send out an email to everybody who attended the webinar. So thank you.
Thank you. And again, we will be including Dr. Lucas from Vietnam as part of this webinar that will be available on our website in the future. So again, thank you so much, Dr. Cho, Dr. Hassan, and Dr. Karpong. Stay well, and we wish you well. And thank you to all our listeners today. We appreciate your joining us. Thank you.
All right,
Okay,
Thank
bye now.
you.
bye-bye.
Bye.
Bye.